My name's Jan Dick. I'm a senior leader at the Minneapolis Heart Institute Foundation, and we are just pleased to have you here today. We've talked about this for months. It is not snowing, it's not blowing, and the ice, I don't think we skated on in too badly, so we feel like we're all safely here for a really important educational event that we have here for you today. I hope that you've enjoyed your lunch, and I first do want to thank our many sponsors. We have Abbott, meaning not the hospital, but the life science group there, Edwards Life Sciences, Luther Automotive, and Medtronic. So really appreciate not only them helping us put this on today, but furthering our education efforts. The schedule today is after me, Dr. Paul Saraja, who is our moderator and the chair of the Valve Science Center. I'll tell you more about him in a minute. We'll give an overview, followed by Dr. Sarah Palmer, and she will talk about collaborating to find the right treatment. And we know that there are people here for all different reasons. You might be former patients, current patients, or people that just want to learn about this important disease. We'll hear from a couple of patients via video. Important part of this program are your questions. And so we ask that you start to form those questions throughout this program. There are cards on the table, and we will be retrieving those and answering absolutely as many of those as possible. Some of them we might congeal because they might be a little bit similar, but please do put those forward. And so a physician panel that will include Dr. Palmer and Dr. Saraja and Dr. Hamid will close our program. So that's what we're here to do today. So I want to tell you a little bit about the Minneapolis Heart Institute Foundation. There is the Minneapolis Heart Institute, where you get your patient care from, and then the foundation, which has been in place for 40 years. It was started, at least this is how I describe it. There were active, creative, engaged physicians who wanted to continue to be active clinicians, but they were highly curious and they wanted to do research, and so they needed an arm to do that. So they created a nonprofit, which is the foundation, and it is still in place today. And it really works. We're agile, we're passionate, we're all about excellence. We have two arms of research. One is industry-sponsored trials, and some of our sponsors are here with us today. And then the other is investigator-initiated research. And both of those create not only options for patients, but also they help change the practice of care globally. We couldn't do this if we did not have the incredible partnership that we have with Allina Health and the Minneapolis Heart Institute, because that's where the patients are. And we, of course, operate, do our work adjacent to the Abbott Northwestern Hospital and also at United Hospital. So MHIF, the foundation, comes in and we help further the research. And then, of course, no research is any good unless we educate, unless we get the word out globally. So in our research arm, we have well over 200 research studies going at any time with well over 2,200 patients that are involved, again, getting those additional options to care. But the news and the discoveries that we make through that research has to get out into the world. So we get community members like yourselves here to hear about what we're learning, as well as we do get our physician colleagues together. And this is done, again, not just locally, not just nationally, but also globally. We also are interested in building the next generation of healthcare providers, so we have an outstanding summer internship program that we're really proud of. None of this happens from thin air. It really does happen through grateful patients, community members that step up and say, I believe in research. I want somebody to learn from what I've gone through. And so we really appreciate the philanthropic generosity of our community. So I'm pleased to introduce Dr. Paul Saraja. I've worked with him now for 7 years, and he is the chair, the Roger and Lynn Hedrick Chair of the Valve Science Center at the Minneapolis Heart Institute Foundation. He's a cardiologist at Allina Health Minneapolis Heart Institute, and he serves as the director of the Center of Valve and Structural Heart Disease there. His expertise is in interventional cardiology, and he has a passion for innovation and getting the best options out to his patients. He's published over 250 manuscripts, several books, and he is a sought-after speaker globally. He just returned from a trip last night, and he has won awards for his medical education. So please join me. Thank you for being our moderator today.
Thank you very much, Jan, and good afternoon, everyone. As Jan mentioned, I did return from an overseas trip last night, so I'm a little beaten up, but I'm really excited because seeing all of you here. It means a lot to us, and as Jan mentioned, we are very mission-focused, educating the folks like you on terms of what valve heart disease awareness is very dear to us, and we're just really, really glad to see all of you here. It's a real pleasure. So I have the honor of kicking this off, and I'm going to share with you a little bit about valve heart disease. And so if we could have the slides up there. Thank you very much. And so February 22nd is Valve Heart Disease Awareness Day. And so we historically have had this get-together on the exact day, but sometimes that day ends up on a weeknight. And we've had some people struggle a little bit with a little bit of the cold weather and getting here. And so we've moved this to a luncheon, and I hope it's okay that we have this on a Saturday instead. But Valve Heart Disease Awareness is next week, and it's this annual event where we talk about valve disease and try to promote what it is and what we can do better in terms of the therapy of these patients. And just to make sure we all understand what valves are in a patient, I think Jan mentioned that some of you may be patients, some of you may have family members who have valve disease, or maybe you have some other interest in valve heart disease. But when we think about the valves and in the heart, just to make sure we're all level set, the heart has two chambers, it has a right and left and 4 chambers, 2 sides and 4 chambers. And on the right side, there's a right atrium or right ventricle that carry blood from the body to the lungs. And then on the left side, there's a left atrium and a left ventricle, which then takes the blood and moves that blood from the lungs out to the body. And these valves, what they are they're a set of structures within the heart, and there are 4 of them. There's a pulmonary valve, there's a tricuspid valve, there's a mitral valve and aortic valve. But on the right side, the pulmonary valve and tricuspid valves essentially keep blood moving in the right direction towards the lungs. And then the blood is then carried from the lungs through the mitral valve and aortic side out to the body. And these valves, they're so important because the flow in the body it's like a river. It's this one-way conduit that's supposed to move all in one direction. Nothing's supposed to go backwards, in terms of circulation. And these valves help things move in the right direction. And so here's some example of these valves. And here in the top left, you can see how these valves normally look when they're open and when they're shut. They're these thin tissue structures. And here in the lower left-hand side, you can see this is an echocardiogram showing the valve opening and closing with the heart cycle. And this is a normal-looking valve, but what happens is that over time, these valves can get a little thick, a little diseased, they can get calcified, and as a result, they can get a little narrow, which leads to pressure buildup in the heart, or they can lead to problems with being too leaky, or you can actually have both. And we commonly refer to stenosis as a valve being too small, and regurgitation or insufficiency is a valve that's being a bit leaky. And this is here in the top right, you can see what looks like a diseased aortic valve. This is actually a specimen taken from a patient who had passed. And just compare how diseased and calcific, thick-looking that valve is versus the top left, which is a normal valve, which is hopefully what most of us were born with. And when we think about valve heart disease, it's a very common condition, and it's very common as we get older, and that's just the natural cycle of life, because as we get older, these valves, which are vulnerable to every heartbeat, start to wear out over time. And in the United States right now, there are actually over 5 million people in the United States with significant valve disease, and 20 million have some type of murmur. And so when you hear about a murmur or valve disease in your family, or maybe some of you, you're actually one of the common people to have this. And so as I mentioned in the beginning, next week is Valve Heart Disease Awareness Day. And I suspect many of you have been familiar or become familiar with a lot of these campaigns with regards to certain diseases like breast cancer or prostate cancer. And so here, this is part of a campaign to make everyone more aware about valve heart disease. And a simple thing to do is, well, which of these has actually the worst survival? And this is an important thing to consider, because I think a lot of us know how impactful breast cancer and prostate cancer can be, as a couple of examples. But when we look at valve disease, it's actually the most malignant of these conditions. One cannot live more than a couple years after you have symptomatic severe valve disease. And what's really tragic is that valve disease is far more curable than many of these other cancers, because it just needs to have the valve repaired or replaced. And that's what we're going to talk a little bit about today. It can be done in terms of therapy. It can be done with an open surgical procedure, and Dr. Palmer is going to give us some insight on that in a moment. It can be done with many keyhole incisions or catheter-based approaches. But the point of this is that there are many options for these patients, or for patients who some of you might be, to repair or replace these valves that are life-saving for our patients. And just to give you a couple of anecdote examples, before I get there, when we look at valve heart disease in terms of how many are treated, this is the tragic part, and this is why we put together these events, is that for every 10 patients who have valve disease in the world right now, only 3 get treated. And it's really a tragedy because there are many ways to impact people's lives with what we do, and I think we can do better. And just an example, I think now I'll move on to how we can affect patients. I think there's audio here, Ed, that might come on. So this is Tim. So Tim had a mitral procedure, and this is him on a slalom ski up north. So up in the lakes somewhere. And I don't know about you guys, but I can't get on 2 skis, and he's on 1 ski. So there you have it. So here's another patient. This is Mabel. And Mabel actually came to our event a few years ago when she was still alive, but she passed at the age of 107. And this is her when she was 103, and she had her valve replaced. And we asked Mabel, and she came to this event and shared her story with many of us who are here. And we asked Mabel, well, why do you want to have anything done? You're 103 years old. And she says, well, it's because I got to go kayaking this summer. I've kayaked almost every year, every summer of my life, and I cannot miss another summer. And she did. Look at that. She's on the kayak after getting her valve replaced, and that's at New Year's the following year. So there are just so many ways that we can affect patients' lives in a beneficial way, and it's because we have new solutions that are now available. So the fact of the matter is, when we think about valve disease, this is a summary. It's got a prognosis that's like cancer, or even worse than some of the most malignant cancers that are out there. We have lots of effective treatments that are available. Most people, unfortunately, are still not treated, and that's just a fact of the matter. A lot of people are actually not even aware of what valve disease is. So we're here because we can do better, and we really think we can. And so what can you do by being here? I think by being here, this is a really amazing thing to see all of you have this interest in being here. There are things online where you can read about valve disease, especially at our Valve Science Center. And Jan mentioned we're in the mission of research and education, and we're always excited to share these things with you. There are advocacy groups. Of course, your care provider, whoever they might be, is a great resource. Some of you may be on Twitter, some of you maybe not. I recently left Twitter and then decided to come back, so I'm on Twitter. We have Facebook as well. But you know, it means a lot to us for you to have this interest, and we're here to share, and we're going to share a little bit more here. So with that, I'm going to introduce our next part of the program, Dr. Sarah Palmer. Sarah, could you come on up here? So Dr. Palmer is a cardiac surgeon extraordinaire. She went to medical school at Northwestern Medical School in Chicago, and then did her postgraduate training at the University of Michigan with some amazing colleagues who I've known for decades. They're just actually amazing surgeons, and she not only finished the traditional program, but she decided to do extra work and specialize in aortic surgery. And she recently joined us last summer as our staff cardiac surgeon, and it's just been an amazing partnership. And when Jan and the team asked who should we have to feature at this year's Valve Heart Disease Awareness, it was easy. It took me 2 seconds. We had to get Dr. Palmer here. So we'll have her talk to you a little bit about a patient-centered approach to intervention, and we'll go from there.
Thank you.
Okay.
It's always very hard to follow Dr. Saraja. He's world famous, very smart, and I'm just a simple surgeon. But I hope that I can share some information with you all today that's not only understandable but beneficial to you, that you can remember. And so I'll repeat a little bit of what Dr. Saraja already mentioned and expand on some of the concept. The heart has two sides, a left and a right, with the 4 chambers and the 4 valves. And some people know this. The way that the valves open and close in sequence with the heart beating is really amazing. The heart is designed as a pumping muscle, and it's really incredible. I remember the first time that I saw a human beating heart in the operating room. I was supposed to be a dermatologist and, was assigned to the OR that day, somehow. And it was very lucky because when I saw, the human heart, and it was Dr. McCarthy removing a tumor from the heart, it was just one of the most incredible things that I've seen. And so from that day I knew, I was probably not going to be a dermatologist. So the heart is a pump, and it circulates to the entire body, and it can't take a break. Your heart beats 100,000 times a day, and if you're lucky enough to make it past 80, your heart will beat over 2 billion times in your lifetime. And so with each beat, these valves are opening and closing. And today I'm going to talk mostly about the left-sided valves, because as Dr. Saraja mentioned, those are the most commonly diseased valves. And this is just a graph showing, when we look at echoes from patients in Minnesota, aortic stenosis is pretty common. And as you get to age 65 and older, we see a lot more patients coming in with this. So this is something that is more prevalent as you age. The aortic valve, is supposed to have 3 leaflets, and it looks like a peace sign when it's closed here. I should point here. So some people are born with 2 leaflets, and that's a bicuspid valve, about 2% of the population. And, it just randomly occurs. And the way that's important is because when it has 2 cusps, it doesn't open and close like a circle. It's more like a ellipse. And so it takes a lot more turbulence across that valve, and so people with bicuspid valves actually present a lot sooner. They'll present in their 40s or in their 50s, so those patients tend to be younger. If you imagine a garden hose and you're just watering your lawn, the water is supposed to go freely out of that circle, But if you take your thumb and you start to cover the opening, that water will speed up, and it speeds up like a jet. The same thing happens with this valve. As the opening gets narrower and narrower, the blood velocity increases across that valve, and the heart has to work a lot harder to push blood through that valve. Now, a leaky valve is very different, and the way we treat these can be very different because they're very different problems. But a leaky valve also makes the heart work too hard because it has to do double duty. It has to pump all the blood that went backward, forward again. So common causes, again, just aging and the calcification of this valve. You can see how crunchy that looks. And actually in the OR, when we're cutting that and taking out those leaflets, it's really hard to cut. It's almost like a rock. So you can imagine this thing trying to open and close. But there are other things that can affect the valve, and these are just some of the most common things. Why treat it? Again, we know that once patients start to be symptomatic, there's not many years after that they can keep going with these kinds of valves. So how do we treat it? Historically, the old-fashioned way is just open heart surgery, and Minnesota is very rich in the history of cardiac surgery. This is Dr. Walt Lillehei. He's often referred to as one of the fathers of open heart surgery. This is back in the 1950s, is really when this field was born. And even back then, he said, what mankind can dream, research and technology can achieve. And so I think that even though they had very simple techniques back then, he knew that this field would kind of take off and accelerate, and that new technologies would be available in the future. So we can repair valves or we can replace valves, and that's a very good concept to understand. Some valves are not repairable, but if it is, it's always best to repair a valve if you can, the valve you were born with. But unfortunately, that calcified valve is not repairable, so those have to be replaced. This slide is not meant to scare anyone, but open heart surgery, you have to open the sternum and put people on a machine, and that's pictured here. The machine pumps the blood while the heart is stopped, and so while the heart is stopped, the rest of the body is getting blood flow. And in the middle picture here, you can see we actually sew this new valve in, and hand tie it down, and then close up the aorta, and it's a new valve. But it takes about it takes a couple hours, and it's a lot of recovery to go through this. There's two options for kinds of valves. This is there's no perfect replacement, unfortunately. There's benefits of a tissue valve, there's benefits of a mechanical valve, but there's downsides to each. And it depends on a lot of factors like age. And, tissue valves are great because you don't need a blood thinner. At the same time, they also wear out because they're not made of metal. So these can wear out just like, your natural valve wears out. The mechanical valve, because it's made of metal, it's theoretically going to last the rest of your life. But the problem is that metal can cause clots, blood clots, to deposit on it. So patients have to be on a blood thinner for the rest of their life while they have these mechanical valves. And it can't just be any blood thinner. There's a lot of commercials out there. There's a lot of new blood thinners coming out. But for these kinds of valves, you got to be on Coumadin, which is also warfarin. And that can be a very finicky drug. It requires a lot of monitoring, and it is a lifestyle adjustment to be on that. So these are all kind of things that we consider when we're choosing, what option is best for that particular patient. So when TAVR developed, it really revolutionized this field. It's probably one of the biggest paradigm shifts that medicine has seen. It solves this problem in a very different way. And TAVR just stands for transcatheter aortic valve replacement. And the first one was in 2002, so this is only 20 years old that we've been doing this. But we've gotten very good, and this technology, again, is such a good way to offer patients who can't have surgery an alternative. So this is a picture of the valve and how we deploy it. It just goes across the valve, and we open a balloon, and then the valve sits in place. There are two kinds of valves, and we'll get into how we choose which one is best for each patient. But there's a lot of randomized control trials that have been done that have really proven the safety and efficacy of TAVR, and we're doing it in low-risk patients now. We used to only do it in patients that were too sick or too old for open heart surgery, but because it's been proven as such a safe and reliable technology, we're almost offering it to everyone. Again, there's a lot of options on the market, but really the mechanism is different. There's the balloon valves and the self-expanding. So the balloon valves are nice. So you advance the catheter across the aortic valve there, and then inside that valve is a balloon, and you actually open the balloon, which opens the valve in place. And you can imagine, how does this thing stay in place? When we do surgery, we have to sew it in. Well, this stays in place because of all of that calcium that you saw, and it kind of anchors it, and it stays put. But because of that, we really have to have the right measurements, the right sizes to make this possible. Now, there is another type of valve, which is a self-expandable valve. So there's no balloon in this one. And how it works is this metal is nitinol. And when it contacts warm blood, which everyone's blood is 37 degrees Celsius, it expands when it warms up. And so you see it here. All we do is remove the sheath. And as we remove the sheath, you'll see the valve expanding in place, kind of like a flower blooming. So again, the technology is just really incredible that we've been able to get to this point. So there's a couple of differences. When we do surgery, we take out the valve. When we do the TAVR, the valve stays there, but it just stays open and anchored. So how do we decide? It takes a lot of smart people. I think Dr. Siraj is very humble, but the cardiologists here are just world-renowned, and without their input and decision-making and skills, I think we wouldn't be able to offer the treatments that we have. So working with them has just been such an important piece of this and such a pleasure. There's also everyone else involved, the nurses, the ICU, even the imaging, the people reading all these images. You go get an echo, you get a CT scan, you get an angiography. We ask you to get all kinds of tests, and that allows us to really plan the surgery appropriately. So, it's very collaborative, and it allows us to bounce ideas off of each other, and it allows us to remain at the forefront. What is the best plan for the patient? There's a lot of things we have to consider. Some people might need more than one intervention in their lifetime. So we have to plan for lifetime management, not just the present situation. And if all things are equal, minimally invasive is always preferred. I think, I love surgery, but it always should be the last option. If there's a better, less invasive way to do it, I think that's really much easier for the patients to recover. But this new technology might not be possible for everyone, so we really have to tailor the plan appropriately. So the ideal patient for TAVR, there's a lot of factors, but people with a tri-leaflet valve, people who have calcium just on the leaflets but not too much above and below, people whose coronary arteries are high enough that they won't get blocked by this valve. And then your aorta and your blood vessels in your legs have to be free of disease, and they have to be big enough to allow these catheters to be pushed up and go up and over. So we have to do measurements of all of this and kind of see, is this feasible or not? Most people are candidates for TAVR, and actually that is the most common way of replacing the aortic valve. We do more TAVRs now in America than surgical valves. So when would it not be possible? And not just possible, sometimes it is possible, but it might not be ideal. So there's a lot of scenarios in which this might be the case. People with bicuspid valves, they tend to be younger, in their 40s and 50s. Sometimes those leaflets are just too calcified and they can't be pushed open by this expanding valve. Sometimes, because it's not a perfect circle, you can have leaking at the corners. You see there can be gaps and you don't have a perfect seal. So then you treat the stenosis, but then they have now a leaking problem. So there's a lot of reasons why a TAVR may not be appropriate for these patients. Again, this is an example of obstructing one of the blood vessels to the heart. The first blood vessels that come out of the aorta are the ones that feed the heart muscle, the coronary arteries. And you can see here, you have the coronary artery starts up here, and it's well above that valve. In a bad situation, you can block that, and you see the artery is gone because the artery is still there, but there's no flow, so there's no contrast going down that. And if that happens, that's an emergency, and that patient then needs emergency open heart surgery, which is much riskier than if we would have just done it electively on a normal day. And there's other things to consider. So not only do you need the right anatomy at the valve level, you need the right anatomy for the aorta. And some people with a valve problem also have an aorta problem. And sometimes people can have aneurysms that need to be addressed. And it's hard for this to anchor to an aorta that's too big. But also, if we treat the valve and then you need surgery for your aneurysm down the line, it's best to treat both at the same time. So for patients with aneurysms, we tend to offer surgery. And here's some examples, some pictures of aortas that might be problematic. So you can see here, this is the aorta in the belly. The device has to come from the bottom up through the top and over. So if you have a lot of calcium or an aneurysm in the belly, it might be difficult to do that. This is a picture of a clot or thrombus in the aorta. And if we push the device up and over, sometimes these thrombuses can get dislodged, and that would go up to the head and cause, a stroke. So we have to look at all of this and make sure that your aorta and all of your blood vessels are normal. Again, these are very curvy arteries in the legs, so it's sometimes impossible to stretch them and straighten them. And so in these situations, we have to be creative, and we have to come up with other ways to deliver the TAVR device, but use another blood vessel. So sometimes we can go through the neck. Sometimes we can go through a small incision in the chest. But again, these are things that we have to plan with the whole team and really prepare for in advance. And with all the imaging that we have, we should never be surprised in the room. And we always have a plan A, B, and C. And so, we're prepared for these situations in the worst case scenario. So there's additional considerations. What if you've already had a valve replacement and that valve wears out? Should you have a reoperation, or should you have a TAVR valve delivered inside that old surgical valve? And there's a lot of factors that help us decide. Now, you're not meant to read this chart, but I wanted to just show there are factors that favor reoperation, and the checks are there. There's factors that favor doing a TAVR within your surgical valve. And so we have to really tailor this to the patient Everyone's situation is unique. Everyone's circumstance is different, and so we really have to give a tailored approach. So again, this is all centered on the patient and what is best in their situation. We have to use a combination of all three of these. We have to use the imaging and the technology we have there. We have to collaborate with all of the other teams, the cardiologists, the cardiac surgeons, the vascular surgeons, the CT imaging readers, and then we have to really try and get the less invasive option if it's possible. So at a place like here where we have a valve center, it's really incredible. This is a picture, this is Dr. Saraja here. This is Dr. Bapat, who is our chief of cardiac surgery. And when we get together in these rooms and we meet every Thursday morning and we plan these cases and discuss every patient, go back and forth and kind of consider all these factors, it's a very good, healthy debate that we have, and it's very collaborative. And it should never be a competition. And I think that sometimes, we can be biased, and we have to really do our best to eliminate our personal bias and do what's best for that patient. The intra-procedural support, that is really key, because this TAVR procedure is done with a surgeon and cardiologist working together. And if something goes wrong, we can do surgery. But the reverse is true too. If we're doing an operation and then the patient is struggling later, we often rely on our cardiologist to take them to the cath lab or do interventions. So we really work together very nicely as a team. And that's how we're able to kind of offer all of this technology. But there's challenges. When you have a lot of options, decision-making becomes more complicated. So again, we always prefer the less invasive option, but we have to avoid our biases. And even though we have this technology, we have to carry it out safely. We have to carry it out appropriately. These are some examples, and this is, I think, supposed to be a movie. Technology has limitations, and there are times where we need to be bailed out. And this image here is a valve that didn't stay put, and it's going to be bouncing around. I think, here you go. So that is one of the emergencies that can happen. This situation here, this is a surgical valve. This is a TAVR inside of that valve, and then the TAVR can have problems, and then the patient would end up needing surgery after that, and we can explant the whole thing. So again, we have to really plan this so that if you're a young patient and you get a TAVR and then you get another TAVR when that wears out in 10 years, 15 years, how many times can you get these procedures, and how do we strategize that? Not just the current situation, but how many interventions are you likely going to need, and what is the best strategy there? So we focus a lot on the aortic valve, and it's a good valve, but it's not my favorite valve. The mitral valve is a lot more complicated. The aortic valve is a little bit simple. The mitral valve is not just a valve, it's really this whole structure. These are the leaflets where the blood goes through the middle, but it's tethered in place here, and this whole apparatus kind of works together. This valve closes under a lot of pressure, and it has to stay closed. And so this is actually a very challenging problem. In some ways, our mitral interventions are a little bit behind our aortic ones, because it's a kind of a more difficult problem. But again, it can be too tight or too leaky. This is an example of a mitral valve that's too leaky because one of these leaflets, instead of matching the other one, it's too stretchy. And so blood will leak back through this opening here, and blood goes backwards. And so that's mitral valve prolapse or degenerative mitral valve disease. A lot of people present with this. And sometimes, if this stretches too much, it can snap, and some of these leaflets can flail and just be flapping away. And that's when patients really start to feel symptoms usually. The good news is those valves are repairable, so that's a good problem for us. Some valves are not repairable. So when it's calcified like this is a stenotic mitral valve. This is very hard to repair. This is an example of a valve that needs a replacement. There are ways that the valve can be calcified. These are just some of the causes. People can have MAC. We refer to it as MAC if you've ever heard that, but it's mitral annular calcification. So that means this whole area around here can have so much calcium that it's really hard to put stitches through, and it can cause a lot of problems. Some people have had rheumatic fever in their lifetime, and rheumatic fever we know causes valve problems, not just the mitral valve, but often the aortic valve and other valves. And then people who have had radiation, sometimes the radiation can affect these valves as well. So again, we have surgical options and we have transcatheter options. This is an example of a repair. So for mitral valve repair, we leave the leaflets in place. You keep the leaflets you're born with, we just have to fix them. So this is an example. Let's say that that area snapped off and had a flail component. We would just resect that, sew it back together so that these had no gap in between the leaflets. And then we put a little ring around it to anchor that support, and then the valve functions normally. And it's your own leaflets, so you don't need a blood thinner, you don't need to worry about it wearing out. This is an example of a replacement of a mitral valve. Again, there's the same two options, biologic valves and mechanical valves. The mechanical valves, in this position, for the mitral position, they need the blood to be thin. So these patients need an INR goal that's higher than the aortic valve. And again, some people, it's hard to take a medication every day at the same time and worry about, your diet affecting that. And so it's a really big commitment to have, a mechanical mitral valve. So there's options that are not surgical, and this is a mitra clip. So I just want to point out, we can put a clip, and by we, I mean Dr. Saraja. This is his expertise, okay? So this is done by the cardiologist, and they can use wires, and they just clip the two leaflets together so that they don't, flail up, so they clip them together, and blood can still come through on either side. And this is a really good option for some patients that have severe regurgitation, but can't undergo surgery, but even reducing their leaking would help. This won't eliminate all the leaking in every case, but it will certainly reduce how much leaks backwards, and patients can feel better just with this clip. Okay, there's a nice video there. Sometimes it takes more than one clip to get it right. It really takes a lot of skill to be able to do this. There's also very many options coming out now to replace these mitral valves. And, some of them have petered out, but we're still doing a lot of trials to figure out, what is the best valve and what can we offer to patients. The Tendyne valve here, I'm just joining this practice, but I'm going to brag about them a little bit. They're really leaders in this transcatheter space, and they did the first implant. They're really experts and going around teaching other people at other sites how to do these procedures. Even places like, the Cleveland Clinic or Mayo are learning from some of our providers how to do these procedures. And the design is it's very cool. So, there's an outer rim, and then there's a valve that sits inside of that. And again, all these are kind of they're designed in different ways, but I'm going to show a little video of how this works. So there you have the outer ring, and within that the valve functions. And again, we can do this all with avoiding open heart surgery, which is really just incredible. I don't know if they really anticipated we'd be able to do this back in the 50s when we started doing this, but it's very exciting because this is all coming out, and I know that the more options we have, the more patients we'll be able to treat. We'll bump that number up, not just 3 out of 10. Hopefully we can get that to 10 out of 10. So I just wanted to end with a couple of points. This should be treated. Severe symptomatic disease should be treated. There's a lot of options. We need to be a team. We need to collaborate with each other. Everyone's different, and decisions are not black and white. It's very complicated. I try to keep some of the details out of it, but when I try and explain it to my family, they have no idea what I'm talking about. But it really takes thoughtful approaches from both sides, and so we do our best when the decision's not always clear. And again, we have to strategize for the long term. So we have to plan these procedures, especially if you need several. So this is just a picture of the valve center. Some of our researchers are here, our cardiologists, our surgeons. And again, we all work together. And even though I'm a new surgeon here, I really feel like it feels very much like home, and it's a very team feeling environment. And again, this is really our pleasure to be able to work together and to talk to you today, to let you know kind of what is available and what are some of the options we have here. But again, thank you so much for listening to this, and I'm happy to answer questions. But again, this is really about education and kind of knowing what's out there. So we really appreciate you coming out and learning about some of these treatments. Okay.
Thank you very much, Dr. Palmer. So at this point, we're going to show a couple of patient vignettes and talk about things, and then we'll have a Q&A. I want to first introduce Dr. Nadir Hamid. Nadir, do you want to come on up here? So Dr. Hamid is not from these parts. She is originally from Singapore and joined us via New York, and is one of the imagers who helps guide us in the procedural aspects as well as the pre-procedural planning. And so I've asked her to join us as well to be part of the panel here. So we're going to first start with honoring Senator Dave Durenberger. Many of you knew the senator before he passed recently. He was very gracious. He participated in one of our clinical trials with the Medtronic TAVR system a number of years ago that helped lead to the approval of that technology now for many patients worldwide. And Dave actually, I can say this publicly because he participated in this event as a patient on our panel in 2018 or 2019, and was just incredibly gracious. And we were really sad to lose him, but we wanted to play a little vignette here remembering Dave.
Dave Durenberger. I'm often known as a former senator from the state of Minnesota, but not for my latest experience, which was getting a replacement for an aortic valve. It was discovered I had a heart murmur in the mid-50s, and somebody told me not to worry about it until I got to be an older person. And so life went on like that until one time while I was hiking mountains, I noticed that I was getting short of breath. When I got back to Minnesota, I called the cardiologist. She said, "You aren't going anywhere until I introduce you to Paul Saraja. What he's going to do is replace your aortic valve because the time has come." At the end of the surgery, here was Paul Saraja looking down at me saying, "Dave, you are lucky to be alive." My valve was 88% closed, which was just a matter of time before that heart was going to stop.
Take Control of Heart Health is supported by the Minneapolis Heart Institute Foundation, working to create a world without heart valve disease.
It was an incredible experience, and just want to say thank you to Dave and his family. So we'll go on here before I lose my emotions and talk about the next patient. The next patient is Jimmy, and Jimmy was an amazing patient. She had a congenital defect and was being considered for multiple different options, transcatheter and surgical. She came to see us, and Dr. Palmer talked a lot about how, as a heart team, we look at things from all different sides, and we want to do what's best for not just the near term, but for the long term. And Jimmy was a great example. She wanted to live a very long time, and we're going to play her video and then ask Dr. Palmer, Dr. Hamid to comment on her story. So we can play Jimmy's video.
My name is Jimmy Golden, and I'm 66. I just retired last June from 27 years of being a massage therapist. I'm an artist. I love being in the outdoors. I love walking and hiking and kayaking and birding. I found out when I was an adolescent that I had a heart murmur, and so I've been followed fairly closely all these many decades. On one of those regular echocardiograms that I was doing with my cardiologist, they called me in, and his words were, "Well, it's time to proceed." I was like, "Proceed?" Wait a minute, you're talking about open heart surgery. So I was 45 at the time, and so that was a bit of a shocker for me. And I was one of the first, I believe it was one of the first 50 people to get a homograph. That was made of human cadaver tissue. And at the time, you know, everybody's hope was that's going to be like your own valve and it's going to last forever. And 20 years was a good run, but what happened was they get super calcified.
So Jimmy came to us with an aortic valve leakage. She has had an aortic homograph 20 years ago, which had degenerated, so it wasn't working very well. If we had left it, her heart would have enlarged. Usually speaking, once it starts leaking, the heart enlarges, and we usually intervene within 3 to 6 months, which is very critical.
And I just thought, I don't know what's going to happen here, but I know I'm in the place I'm supposed to be. These people know what they're doing. I just need to relax.
And luckily, we have many options today. One of the options, of course, is traditional second open heart surgery. But the second option has emerged now for the last decade is what is called as a valve in a valve. And that's less invasive. Only thing is, we are still learning about that field. First is in which patients is appropriate, and more importantly, how long that combination can last.
I really recommend people get second or even third opinions because you'll be shocked by what different choices you're given. And if you're not given different choices, then that gives you really good information too.
This case is actually a perfect example. If, say, we had done a valve in a valve, which probably we could have, she would have presented to us for a more complicated open heart surgery at age of 72, 75, bit unpredictable. At that time, as we know, with time we only get older, unfortunately, we may have some other health issues. So at this time, we felt that if we do a second open heart surgery, the risk in that will be still low in my hands. Then she doesn't have to worry at age of 80 probably when this valve degenerates. She can then have a valve in valve.
There was something this time about it. It's like, I just need to let go and trust that it's going to be okay. And I kind of treated it like it was a meditation retreat going in. I know that sounds insane, but the way that it was for me was to just be present with whatever's happening.
Everything has improved, so much so that we can literally look into the heart of the patient before we open the chest. And that gives us tremendous confidence in keeping the operation really compact.
The ICU nurses were commenting that even though I had the ventilator in, I just was smiling. So I think I was so relieved. This is the whole reason I did this, just so I could see you. How are you?
Good to see you. You're doing very well.
Oh my goodness.
Good to see you.
I think I am doing very well.
You look fitter than me now.
I don't know.
She's amazing. She looked fitter than me, better than me, in every possible way, and I think she walked even faster than me. So I think I need to get fitter than Jimmy.
I've been able to go on 3-4 mile walks when it's not completely icy outside. Before surgery, I just didn't have energy to do anything. And so I wasn't doing any art for a long time. And so in this, starting about, I guess 3 weeks ago, I started doing art again, which has made me happy.
Any open heart surgery in a patient is a big event, and we don't take it lightly. Our intensive care at Abbott Northwestern is just excellent.
And it's not just that I felt like I was technically well cared for, which I was, but there was just some real loving kindness, coming from some of those, I'm gonna make myself cry, coming from those team members that just really moved me. I've actually been working on writing a thank you to send to them. And it's just what words possibly convey thank you for my life, thank you for taking such good care of me. I hope to live a life that's worth the time and energy and effort that has gone into keeping me alive once again.
Well, it's pretty hard to beat that.
Yeah.
So, let's talk about this a little bit. So, Nadir, can you tell us a little bit? Vinny had mentioned we can see a lot of what's inside the heart before we actually open things up. You're the imager here. Can you talk to us a little bit about what's at our disposal that allows us to see things inside and predict what someone like Dr. Palmer is going to see when they open the chest?
Oh, that's a great question. Thanks, Paul. I mean, I'm a humble imager, and I'm truly honored to be here in Abbott Northwestern to work under world-renowned Dr. Paul Suraja and Dr. Palmer as well. We work so closely together, and as an imager, we are the first eyes for the patients. We do the ultrasound, which some of you may have undergone, a transthoracic ultrasound, which is just putting jelly on the chest and taking images. There might be some pressure on the chest as I press, but really to capture the images in multiple views to really see the heart, how is it functioning. And we look at the entire heart, not just the valves itself, like what Dr. Suraja and Dr. Palmer mentioned, to see whether it's leaky or is it tight, but we really look the heart as a whole function. We can tell both of them how the heart is pumping, the heart function, in terms of the left side and the right side, and what effects that the tight valve or the leaky valve has on the other chambers. And that gives us a precursor as to what is the next intervention for Dr. Suraja or Dr. Palmer. Is it a surgical or is it a transcatheter approach? And sometimes, we do need more information. Sometimes on the chest we are limited with the rib structure. A little bit of the fat pad as well may be challenging for some patients to really visualize what's exactly going on. And so there'll be conversations with your cardiologist in clinic, including myself, Dr. Suraja, Dr. Palmer, say we need better visualization. So instead of a cardiac CT, what we do is a transesophageal echo, which is similar to an ultrasound, but essentially passing a probe down your food pipe, because where the position of the heart is and where the probe is, we'll be able to see the heart a little bit better in terms of the heart valves and the heart function. And what I love, which Dr. Suraja and Dr. Palmer also know that in every Thursday morning, is that I tell them how bad the valves are doing. I quantify in terms of the minuscule decimal point as to how tight this valve is and how leaky this valve is, and to give us that grade of severity of that leaky valve or the tight valve. And so these are the first two tests which some of you may have undergone, which gives us a great snapshot of the heart. And so like the patient, Jamie as well, would have undergone these two tests, and also including other tests like a cardiac CT. And like what Dr. Palmer said, gives us all this information and then discuss at the a regular valve meeting and discuss as a group as to what is the next best therapy for the patient.
Sarah, Jimmy mentioned that some patients might have anxiety about coming into these procedures. What can you tell these patients to get them to do a meditation like what Jimmy obviously had to do before she came in? What can you do to ease their minds about having an open surgical procedure?
That's a really good question. I think that trust is probably one of the most important things when you're putting your life in someone's hands to do a procedure, a surgery. I think trusting your provider and having a good relationship where you can ask questions, you feel like you understand, you feel like you're being heard. And I think here, we really hope that we provide that. I never want people to leave the clinic appointment, oh, I wish I had a chance to, ask all these questions, but they just rushed out of the room. So I think we really have to establish trust with the patient. We have confidence in our skills and what we can offer, and we really have to be empathetic providers as well. It's not just, can you do the job in the OR, or can you do the job in the cath lab? Connecting with the patient, I think, is just as important. And once you have that trust, I think that anxiety, it goes down. And we've had a lot of anxious patients. I think if I needed surgery, I'd be anxious too. So that's really, I think, the most important thing.
Great. Do you have some questions from the audience?
Yeah.
So we'll take some.
So if people have questions, there are
Yep.
note cards on your tables, and you can just write on them and
Yeah.
raise them up, and we'll come collect them.
Yeah. And if you don't have time to write, you can also just shout out your question too. Not a problem. Okay. Okay. Well, this is a great one. So, Dr. Palmer, so first one, I have had 2 valve replacements. What happens if I need a replacement a 3rd time?
Yeah. So there's a lot of questions that I need to ask to know, but the most important thing is, every time we do a replacement, that area gets smaller. So if we have a surgical valve and then we do a TAVR and we expand it inside of that, and then we do a 3rd thing and we expand it inside of that, eventually you kind of run out of space. So I would want to know, what size valve they currently have, and I'd want to know things about, their health and can they tolerate another operation. Like I said, it's always best to be minimally invasive. So I think if you've already had 2 open heart surgeries, and this will likely be the last intervention that you have, I would recommend probably a transcatheter approach in that situation.
As long as it's technically feasible.
As long as it's possible.
Yeah. Sometimes a 3rd reoperation or a 4th reoperation is just necessary.
Yep.
And that's where the heart team and the evaluation becomes very important. Adira, can you answer this question? So the question is, at what point do valves need repair or replacement? Maybe just talk to general indications for timing of intervention.
Thanks, Paul. Great question. I think it's, once there's detection of a murmur and you had an ultrasound scan, the echocardiogram, it depends on the severity of the disease, whether it's leaky or is it a tight valve. I think, if looking out for symptoms, that's number one, which, you should liaise very closely with your cardiologist. The secondly is regular follow-up with regular ultrasound scans, whether is it a yearly or 6 monthly. It all depends on the severity of the disease itself. And I really would advocate, if you have any symptoms, any shortness of breath or any out of the ordinary, as you all know your own body, to really seek out medical assistance and reach out to your cardiologist, that you may need an earlier intervention other than waiting till something, heart failure symptoms or anything else that happened.
How do you know if it's somebody's having symptoms or it's just because they're getting older? It's a common question, right? It's a very common question. So
it is. And
so what do you tell patients?
Oh my God, I tell my patients, you know your body best. Simple things that you used to do. It doesn't have to be running through a track, something simple that you used to be able to do and you just can't do it now. Out of the ordinary, there's something wrong. walking out a dog. I have a patient who's, who used to be able to walk out a dog, just a couple of weeks ago, and now he can't do it. And I knew something was wrong, and that's when I undergo investigations. So I think don't put off the symptoms. That's what I say, but really reach out to your cardiologist and discuss with them. Is this out of the ordinary for me? Whether do I need further testing? And I think that's where, your 1 out of 3, the 3 patients, that you showed that these patients are treated very late. And when these patients are treated very late, you have a lot more complications, a lot more comorbidities, you're sicker. And so having any form of intervention, be it surgery or transcatheter, may pose a little bit more complications. So I would seek early intervention with your cardiologist.
So when in doubt, ask.
Absolutely.
All right, that's perfect. Okay, Sarah, can you talk a little bit about the different options for aortic valves, mechanical and tissue, and along those lines, the recovery for TAVR versus SAVR in terms of the options?
So the choice of a tissue valve or a mechanical valve is probably one of the trickiest things that I talk about with patients. One of the biggest factors is age. So it's pretty clear cut that people who are in their 40s or 50s who would like a valve to last the rest of their life, those patients should have a mechanical valve if they're okay taking blood thinners. But patients who are in their 70s or 80s, I think a biologic valve or a tissue valve from an animal is better for that option, because you don't want to be on blood thinners if you don't need to be at that age. The decade that's the hardest to decide are people in their 60s. And so at that point, we have guideline recommendations, and part of the guideline says, what is the patient's preference? And so it's not a decision that I make, it's a decision we make together on what's best for that person. And everyone has different, values. Some people would rather not take any medications and have a surgery in 12 years. Some people never want to do that again, so people are different. And so I think talking with your patient and figuring out what they value is very helpful. The second question that you had.
TAVR versus SAVR?
Yeah.
And blood thinners, no blood thinners?
Yeah, so the recovery is very different. Sometimes I'm shocked at how good people look after open heart surgery, but it's at least 4, 5, 6 days in the hospital at least. And that's if everything goes well. You can have some complications that come up that will keep you there longer than a week. But it's a world of difference in terms of recovery. Our surgical patients take about a month for their chest to heal and for the bone to heal back together. And I say at least 2 months, 3 months to feel like you're back to yourself. The transcatheter valve, patients are home the same day sometimes or the next day. They're walking around, they don't have an incision, and so the recovery is a lot easier. But again, we have to think, it's always tempting then in that to pick the easier recovery, but you have to think, what is the options down the road? So
right.
that's part of the decision making.
Nadira, could you answer this question? There are actually several here. They all ask the same thing, so this is a hot topic.
Oh.
What causes calcification? Is calcification the same thing as sclerosis? And does COVID have anything to do with it?
Oh. Oh wow, that's a lot.
Just simple ones.
Simple ones.
Calcification.
What causes calcification? There's so many. When we see young patients in clinic who has aortic stenosis, the first thing that comes to my mind, as Dr. Palmer highlighted in her presentation, whether the patient has a bicuspid aortic valve. And these patients who are young with bicuspid aortic valve, there's different reasons as to why the valve degenerate. Is it being tight or being leaky? And it's part of the disease process with bicuspid aortic valve, because the tissue itself is very different from someone who has 3-leaflet valve. And so in another elderly patient, 70 or 80-year-old that we see in clinic with severe aortic stenosis with a lot of calcium, a lot of the examples that Dr. Palmer highlighted, the calcium being at the leaflets or can be above or below the valve. And that's through just degeneration over a time period of, lifetime. And the disease process varies according individual patients. We are learning a lot in our studies and literature, and there are studies, even trials, trying to see if we can slow down, if there's any medication to slow down the disease process of calcification. Of course, these are all research. There's still much more that we can do, in this process, but it's very promising. And so really, I think the vendors and the sponsors are working very hard with a lot of top-notch physicians in multiple institutes to really understand this physiological process, to slow down the calcification process, and hopefully, who knows, in 5-10 years we may have a pill, that we know once we detect on ultrasound is someone who has sclerosis with maybe mild aortic stenosis, we'd be able to take a pill to slow down that disease process. And so these are things that we are looking out and looking forward to.
We actually have a clinical trial that's randomizing patients for a medicine to stop the calcification. So some of you might be interested in that, but that's launched here.
And I just wanted to add a couple things. I always tell patients, they say, is it because I eat eggs and my cholesterol and all this stuff? There's nothing that you did that caused that calcification. It's just the body's process of, trying to repair itself. When there's a little bit of damage, the body, it's smart in some ways and not smart in other ways. And so in trying to repair itself, it calcifies. And it just, again, happens with aging. Some 80-year-olds will have perfect valves. Some have very calcified valves, and we just don't know who's going to develop it. But I always tell people, it's nothing that you did. It's just bad luck.
I had an 83-year-old patient 2 weeks ago who asked me what in their diet should they change for valve disease, and I said, ma'am, with all due respect, when I'm 83, I'm going to eat whatever I want, and you should too. So it's what it is. So just a couple other ones. There was a question about what causes the TAVR to open and close. It's the natural motion of the heart. So the heart's pressure opens and closes the valve. There was a question about do all Minnesota hospitals have the technology available? And so many of them do. Many of the ones that are commercially available do, but there are only so many hospitals that have research trials. And so if you're interested in some of the cutting edge ones, then our hospital like ours or other research institutes can help you there. There was one other question I had here. Oh, okay, maybe one question for you, Sarah, and then I'll answer the last question here. When a valve that's been repaired leaks again, what do you do in that situation?
Yep.
Mitral or aortic?
Yep. So, again, repairs are always ideal, but they're not perfect either. And sometimes the repair is not durable. And, when people have stretchy tissue, like that mitral valve that was very stretchy and not touching each other again, that process can continue and things can change. And so if you've already had a repair, then it's probably time for a replacement the second time around. And usually people are older, and it makes sense to do a replacement at that point because it doesn't have to last, more than 15 years. But again, the first time around, if you can repair it, that's best. Replacing it, though, is always a backup option.
But we wait until there's severe disease
Yep.
or severe symptoms of concern before jumping in. So, the last question that was here was what are we most excited about for the future of valve disease and research? And I have to say, the way I often describe it is, we all get smaller, and so it's human culture. If you think of our phones, many of you remember how big our phones used to be. Remember, the first pacemakers that were invented by Medtronic and others used to be these grocery carts, that people push around. And now everything's really, really small. And so that's the way I think a lot of our procedures are going. And every year we get approached with new technologies that are able to do things that used to require open, big procedures with smaller, less invasive. And it's hard to imagine a world where I can match what Dr. Palmer does with open surgery, but we're gonna die trying. And so in 20 years we've come a long way, but it still requires a very collaborative approach, and I'm honored to share what I do with these colleagues and many others. And so we'll finish it on that note, and several of us will still be here. I know we didn't get to all of your questions at this time, but I promised we'd end on time as well. And I want to thank you all for being here. It's really been a privilege, and I look forward to talking with you some more and seeing you again in the near future. Thank you.